the field of surgery, though that's been the standard of care for treating cancer for centuries, has had advances even in the last few years that have profoundly changed the risk-benefit ratio, because it's become possible to now do surgeries with lower and lower risk as it becomes more common to do them through minimally invasive surgery techniques and robotic platforms, and really a lot of advances that have occurred just in the last several years. And so for all the advances we have in the idea of treating a single area with radiation, surgery also has its role to play, both in the setting of oligometastatic disease and some other settings where it may be appropriate to consider surgery for patients with stage 4 disease where we traditionally had not considered surgery as having a place. So with that, I'll have Eric take over. Thanks.
Thank you, Jack. I apologize, my voice is off. I was at the soccer game 2 nights ago and I did yell a lot. It's interesting that Vivek put that slide on. I personally see that as fake news. It's a strategy that we have here locally to keep people from moving here. It works. Our weather is a lot better than advertised in movies and so on. All right, let's talk about surgery. And there are 2 roles that surgery can play in the topic that we're covering today. One is diagnostic, and the other one is potentially therapeutic. And I'll cover the diagnostic part quickly in that there are instances where there have been an attempt to biopsy something that's left there after systemic therapy. You're not sure if it's cancer or not. Knowing would have an impact on how we do things. And there's been an attempt with a radiology or bronchoscopy approaches to get a diagnosis, and you don't. And sometimes surgery is the way to go, where we'll go ahead and remove an area so that we can give the pathologist more tissue to answer questions about what's left behind. It also, at this time, allows to perform additional, what I call omics, whether it's gene or proteins or whatever you want to interrogate the tumors with, to better maybe tailor your systemic treatments, though that may change over the years as the minimally invasive, the smaller samples are needed now to answer some of those questions than they used to be. So there may be a role, remember that, for surgery in the diagnostic side of the algorithm at some point in time in the management of these patients. As far as treatment is concerned in the setting of oligometastatic disease, we've been doing this for over 50 years in surgery, not in lung cancer, but in other cancers. And it's been alluded that we've done sarcomas, renal cancers, colon cancers, instances where there is a very small amount of disease in the lungs only, years or at the time of diagnosis of another malignancy. So we do have a long history of having treated oligometastatic disease. The issue here is that we've never done that for lung cancer, and this is where the interest right now lies. As Jack has said, surgery that we do today, the techniques that we have, is definitely not the way I was trained to do it 25 years ago. That's changed enormously. As much as Vivek has talked about all the new tools and excitement that they have and all the gadgets, we have the same. And it's not just the technique. We've learned something we called ERAS, which is Enhanced Recovery After Surgery, which is not just for thoracic surgery, but also in colon cancers, colon surgery and others. We've learned that there are things that we can do before surgery, during surgery, after surgery, to make the experience a lot easier for the patients, shorter stays, less morbidity, and so on. And it's as simple as giving your patient a load of different medications before surgery to target pain, whether it's narcotics, Tylenol, anti-inflammatories, a cocktail of all of the above. If you do that before surgery, we know now that the experience of surgery and the recovery from surgery is easier. So we've learned that, and that's part of the reason why surgery is easier on patients today than it used to be. And it's not all about the technique of surgery, but really of the entire experience has changed. As well as things that we can do during surgery to minimize difficulties after surgery. There are anesthesia techniques that when you're doing one lung ventilation, you protect the other lung, that helps. There are different ways of controlling pain during surgery. We used to have epidural analgesia only. Now we have paravertebral catheters, intrapleural catheters, blocks. We can do muscle blocks in the serratus muscle, the latissimus dorsi. There are so many ways now that we can help with pain control, all of which have their own advantages, disadvantages, that we can offer a much better combined product with surgery. And in the post-op phase, we also know that using the multimodality approach to pain control, minimizing narcotics, and the list goes on, we can improve the experience. About the technique of surgery, yes, we do have minimally invasive platforms today. There are basically three. One is called VATS. That stands for Video Assisted Thoracic Surgery. It's been around for over 25 years, but it really has caught up over the last decade or so. There is a modification of a VATS called uniportal, where you do a VATS, but it's only through one little incision. That hasn't caught up as much in North America. It's driven a lot by Asia and Europe. Advantages have yet to be seen. There is a cosmetic advantage, there's only one incision, but that's probably where it's going to be. And then there's the robotic platform, which is new, novel, improving, not where it's going to land. It's definitely in its infancy, but also that may have potential advantages. But all of those three are minimally invasive platforms. And what basically defines a minimally invasive platform is that you don't spread the ribs to do your operation. That's it. If you do your incision through your surgery through an incision that's 6, 7, 8 centimeters long, but you don't spread the ribs, that also is a minimally invasive approach because the recovery is so much easier. Not only that, in the open platform, which I still do lots of, I'm not doing it the way we were trained to do it 25 years ago. We don't open the ribs as much as we used to because we've learned that this is where a lot of the recovery issues were. And we can do that, why? Because we can bring the instruments that have been developed in the minimally invasive world to the open world, and as a result of that, even the open surgeries are a lot easier on our patients than they used to be. So there are major advantages in that there is less pain, which is really what's been slowing our patients' recovery, shorter hospital stays. I'll do a wedge resection in the morning, send patients the same day. I'm sorry, this is not the way we were trained. We'll do a lobectomy, which is to remove one of the 5 lobes in a patient, get them home at day 1 or day 2 or day 3. When I was in training, patients were in the hospital for 7 to 10 days. So these are all improvements related to everything that we've learned of how to handle surgery. And as a result of that, there's less complications and less morbidity. Now, one of the operations that we are sometimes asked to do, particularly in a patient who has oligometastatic disease, is kind of a wedge resection, which is basically removing the disease with a rind of healthy lung around it, very similar to what radiation does. It treats the disease only and a little rind around it. Those wedge resections are not all the same. So not every wedge is the same. There are locations on the lung, on the corners of the lung, on the corners of the lobe where a wedge is very technically easy with very little risks. There are other wedges that are a little more risky, and that has to be part of the discussion as well. And at times we're asked to do what I call salvage surgery after radiation. And I have to say I've done a lot of that over the years where patients were treated with radiation first. There is a lack of control and everything else looks good. The patient is still a candidate for enhanced local therapy and will go in. And as a result of all these new technologies that Dr. Mehta has described, I can assure you it's a lot easier to go in and do a salvage resection after modern day radiation than the old way of doing 6 weeks of radiation where the entire chest was like cement. Today it's easy. It's like you're wondering, has anyone been here before? There's no scarring. And that's as a result of being able to concentrate the treatment around the tumor. Now, when we talk about doing a local therapy to someone who has systemic or stage 4 cancer, we also have to weigh in what the impact, be careful that the impact of our local therapy does not interfere with the ability to continue the systemic treatment, which is really most likely what's kept the patient in doing well. So again, if you're going to contemplate doing an operation on someone who's been maintained on immunotherapy or a tyrosine kinase inhibitor for quite some time, If you end up with a bad complications from your surgery and suddenly you cannot continue those agents, you're not helping this person. So you got to be careful when you make those decisions that you are not going to break this this systemic therapy in a way that will interfere with the patient's ability to continue to do well. I think that as systemic therapy improves, and that's what we're seeing right now, that's what today's topic is about, is as systemic therapy improves, I believe there will be, and we still have to determine who these patients are and what modality we're going to use. Is it going to be radiation or surgery, or sometimes both? There's going to be a bigger role for surgery and radiation. I think those decisions have to be made in a tumor board setting or a multimodality therapy setting, because not all patients are ideal for surgery in that setting. Not all patients are ideal for radiation. There are instances where one modality may be superior to the other. And until we have more data on that, I think those decisions have to be made in multimodality tumor board setting. We've talked a little about the cost of doing things here in some of those slides and some of the topics that we've done. And I actually think that's going to have to come into the equation. This is something we've never really looked into very hard in this country. But, and this is where the difference in between radiation and surgery, we're going to have to analyze the cost of these modalities, and we're also going to have to analyze the cost of the combined treatment. And this is one area where I think surgery may be a little helpful. What if there was evidence that with immunotherapy or other systemic treatment, probably more with immunotherapy, after a while, if the patient was rendered no cancer, you could stop those, they're very expensive treatments. What if we could show that? So you have someone who's been maintained on immunotherapy, there's still a spot in their lung, and you're wondering, is it all gone or not? And you go, well, let's take it out. And if it's all dead, we're going to stop the treatment. And maybe we'll get there one day. And that may be one advantage that surgery will have over radiation, in that we'll know that this was a complete response, and maybe that information would be helpful in determining how long we should treat these patients. I'm not saying we have data to support that. This is just an idea and a thought. Quality of life, I think, has to be part of any evaluations that we make of those local therapies in oligometastatic disease. Right now, we're looking at prolonging survival, hopefully maybe improving survival, but we cannot forget quality of life of our patients in any intervention that we recommend, surgery being one of them. And if I'm going to go in there and take a patient who has no chest pain whatsoever, do an operation, and then they have chest pain forever after that because of what I did, I'm not sure this is all. We got to monitor that. And then there's in my book, there's one really big unanswered question. There's a lot of that excitement about promoting local therapy in oligometastatic disease. It's just going to get bigger with immunotherapy, as we've hinted today. But there are some hints that there may be synergy in between some of the local therapy and the immunotherapy, mainly with radiation. Will we see similar synergy with surgery, or will it be the opposite? Is it possible that with surgery you knock off the immune response that the immunotherapy allows? This whole area is, to me, as an oncologist, is very exciting, because this is something we're going to have to examine. And Puneeth has already alluded of the timing, the sequence of those interventions. Well, that's part of that. So I think this is an incredible field. I think as systemic therapy, because that's been, for local therapy, the problem has always been the systemic failures. And as we've improved systemic treatment, we have to go back to the drawing board and see how can we help with local treatment, and will this have an impact? I don't have any slides. Thanks for your slide, V. I'll take any questions. So the question is whether some individuals with their stage 4 disease is defined by the fact that they have pleural disease. So disease in the envelope of the lung, usually ipsilateral on the side of the cancer. And the question is, do we think that there may be a role for a pleural procedure in an effort to improve things? Historically, that's been looked at, not in high volume, but particularly there was a study out of the Brigham in Boston where they were doing very well in their mesothelioma program, they were doing aggressive pleural surgery. And the concept was, why don't we bring that to the patients with limited stage 4 pleural disease? And the results were not, at that time, did not support that approach. There was one study out of Asia, small numbers, potentially supporting that approach, but that's all there was. I think you're asking a very good question. As systemic therapy improves, is this another area where we should reevaluate the potential role of a pleural procedure, and probably more along the lines of a pleurectomy, which is to remove just the lining, the envelope, over that of an extrapleural pneumonectomy, which is that you remove everything that's in that chest, the lung, the pleura, the diaphragm, the pericardium. These are massive surgeries. So I don't know the answer to your question. I do think that, I'm repeating myself, but I do think that as systemic therapy gets better, this may be another area we should explore. So the question is, he's being very diplomatic. The question is, are there times where surgery or radiation would be a better option? The answer to that is yes. And I think there are times where those decisions, and we do that regularly every week on Friday morning, we look at some of these cases and we decide as a group whether we think surgery or radiation would be superior. I've alluded to this in that not every wedge resection is equal. There are places in the lung where a wedge is in and out, half-hour surgery, you're going home the same day. But there are places in the lung where a wedge resection carries a risk of a significant loss of lung, significant risk of air leak, which would delay your recovery, leave you in the hospital for quite a long time. And these are the decisions you have to make. Similarly, there are places where radiation is not as easy. If it's right on the diaphragm and it moves in enormously with every breath, it's a lot easier for me, if it's right on the diaphragm, to get it out of there than for them to track it. One of the risks of radiation, if it's too close to the chest wall, is radiation to the adjacent rib and rib fracture. The risk is low, So these are the discussions that we need to have. As far as lung-sparing surgery, well, we can do now today. We talked about wedge resections, but we could also do what's called a segmentectomy. Not all segments are equal. There are segments that are easier and carry less loss of lung than others, but these are options that we have as well. Segmentectomy is not a new operation. It's just coming back to the forefront because we're seeing tumors that are amenable to that. So the question is so historically in lung cancer, we thought the standard of care is a lobectomy. That was based on a study that was done in the late 70s, early 80s. Today, we know that there are tumors where lobectomy is an overkill. We can do less and have as good results. This is based on, right now, not randomized data, but a lot of strong data out of mainly Asia, Japan. There are 2 randomized studies that should hopefully soon publish their results that are looking at this. But the issue is the same here, is if the concept of the operation we need to do in the oligometastatic patient that you don't need to do a lobectomy, yeah, you can apply those same operations.